Oh,
Yeah. I got stuck. I got into the repatriation scheme. Still, my name didn't come out.
Okay, all right. Shall we start? I mean, Dr. Chitra?
Yeah.
Yes, it is my pleasure to welcome Professor Joe Thomas. And just a few words of introduction. Professor Joe Thomas is an accomplished international development professional, academician, public policy expert, and a human rights activist. Till recently, Sir was teaching at MIT World Peace University, Pune. He has now gone back to Australia, where he is Professor of Public Health, Institute of Health and Management, Melbourne, Victoria, Australia. And sir, we welcome you to enlighten us on Australian healthcare system, problems and prospects. The floor is yours, sir.
Thank you. My voice is clear. Can you hear me?
Yes, sir.
Yes, sir.
we can.
These are some of the customary introductory note nowadays. This is evening 7 o'clock. You're having a session on Australian healthcare system, and that shows how much you're keen to know about an interesting healthcare system. The title was proposed to us at healthcare, the problems and prospect. And I was thinking that what problems of Australian healthcare system, I shouldn't see much, but I'm not saying it's not there. So that gives an introductory tone. And many of us, we claim that one of the best healthcare system in the world is in Australia. And when you say the best, depends on the certain criteria, like life expectancy, access to healthcare, and also out-of-pocket expenditure. So some of the standard indicators, infant mortality rate, neonatal mortality rate, maternal mortality rate, all these indicators when we look at it, and Australia demonstrates one of the very exemplary healthcare system. But at the same time, there are a few other issues coming up. And in my presentation, and to begin with, I should thank Professor Rajshekharan also, because even though, I am part of the Australian healthcare system, I teach, I create syllabus for them. I never looked at comprehensively on the healthcare system, and also I'm a beneficiary of Australian healthcare system. So this gave me an opportunity to sit through and put together my thoughts and some of the points about Australian healthcare system. And what I want to talk to you today is, or rather discuss today is, the Australian healthcare system, if I may present it in one sentence, it's a comprehensive healthcare system. And the foundation of Australian healthcare system is what you call Medicare. So I'll just briefly introduce what is Medicare. And the Medicare benefit scheme, that's one of the supplementary scheme of the Medicare. Then the pharmaceutical benefits scheme, PBS, that's also part of the core component of Medicare. Then Australia has got a very unique public and private healthcare system. And particularly the primary healthcare network. So that gives one of them, I would say, the backbone of Australian healthcare system. And also, unless you look at the health financing model of Australia, it may not make sense. And I'll just highlight some of the challenges which our Australian healthcare system is facing right now. Then I would really like to take some questions and answers. And I would like to get into an engagement with the issue of Australian healthcare system. So this is my general, these are the points I would like to talk to you. And my understanding is that all of you are the MPH students and with some faculty. So this is the audience I hope I'm talking to. So yeah, because when I created the slides, I created according to the possible audience, who are the public health students, maybe first year and second year students, and a few faculty. I hope I'm right about my assumption regarding my audience.
yes, sir.
And maybe I'll begin with a few demographic indicators of Australia, because that gives the contextualizing the healthcare system in Australia. Australian population is approximately 25 million. That's slightly less than the Kerala population. And what we talk about is 25 million people are every year added to the Indian population. So that's one of the interesting demographic comparison between India and Australia. And yearly population growth is only 1.8%. So that's population growth-wise is one of the lowest. And its global share is only 33.33% of the global population. And any demographer, when you look at it, the TFR, total fertility rate, is 1.8. 1.8 means, that that's a negative population growth. Even with 1.18 population, the natural population growth, Australia is not growing, it's stagnating. And the life expectancy at birth in Australia is both sexes is 83, that's 84 years. This is an interesting dynamics I'll just explain to you. This is covering certain facts. So when you say that life expectancy in birth in Australia is 84 years, that is not revealing, there is revealing something, but at the same time it's concealing something. And the life expectancy at birth of female is 85 or 86. If you look at the infant mortality rate, the death of children under 5 years per 100,000 live births is 2.7. So that's one of the lowest in the world. And it seems even in the United States, it goes up to 6 to 7%. And also, if you look at the demographic change, over the 20 years between 1999 to 2019, the proportion of the population aged 65 years and over increased from 12.3 to 15.9. That's the elderly population in Australia. And also 2015 to 2017, the life expectancy at birth for the indigenous Australian was estimated to be 71.6 years for male and 75.6 years for female. So this is the data I said, when you talk about life expectancy at birth for Australia, in general, it is 84%, but indigenous population is 72%. Approximately 10-year difference between indigenous population and the white Anglo-Saxon population. So this is one of the major challenges in Australia when you talk about it. So this is the demographic background in which we are talking about the health situation in Australia. And also it is considered as one of the better life expectancy in most of the OECD countries and most of the Western countries. And when you compare to most of the Asian countries, they are much far ahead of that. But what contributed to that during our discussion, we'll look into it. And as I mentioned, Australia's health system is considered as one of the best in the world, providing safe and affordable healthcare for all Australians. And affordable healthcare for Australians, that's one of the unique aspects of Australian healthcare system. But when you look at it, this jointly done by the Australian federal government, state government, territory government, and the local government. This is, if you compare with in India, the national federal government, state government, the panchayats, and the local government. So this is a combination of different players. But all these players are very uniquely aligned with each other, and there are the mechanism for this alignment is also an important part of the Australian health policy. And also when you look at the healthcare system, Australia has a very comprehensive healthcare system, and that's also one of the most advanced globally, offering a range of services. And like many other countries, if you need a specialized care, you have to go to private care, you have to pay out of pocket. But in Australia, that is not the case. You get long-term care, specialist care, or ordinary hospital care. All can be you can access from the government-sponsored public hospital. One of the best hospitals in the world is in the government sector in Australia. If you look at the best pediatric hospital in the world is Australian Melbourne Pediatric Hospital. It's a government hospital. Alfred Hospital is one of the best hospitals in the world. That's a government hospital. That's very unique in Australian context. In many other countries, the best hospitals are in the private sector. And when you try to understand the healthcare system, you have to understand the Medicare. The Medicare is the system or the program that is the foundation of Australian healthcare system. The Medicare means that is the demonstrated symbol of Medicare is all the Australians or the PR, permanent residents, they'll get a card, a green card, and there's a number, the name of the person, and name of the people who are beneficiaries of that. With this card, you can access almost all the healthcare services in Australia. But with certain caveats, I'll come to that. And most of these are free. But at the same time, Australia is also actively promoting a private health insurance. And that gives, this doesn't mean that there are no private hospitals in Australia. Some of the good hospitals also in Australia are private hospitals in very specialized areas like reproductive health issues, research in the area of embryo, the artificial, maybe let me put it in a different, the Australian government is supporting reproductive health by even for insemination through publicly supported financial care, not, that service normally in many other countries is privately financed. Just to give an example about to what extent it goes. And it's also covered under Medicare. And Medicare is Australia's universal healthcare system since 1984. It's one of the long-running healthcare system. And also Australian Medicare is available for all the Australian citizens, all the New Zealand citizens, permanent residents in Australia, and the people from other countries with the reciprocal agreements. For example, UK, some of the European Union countries, Japan, Korea. So you have reciprocal arrangement with those countries for the medical care. And when you try to understand Medicare, it has got three major parts. One is medical services, supporting other public hospitals, means government hospital, then ensuring access to medicine. So these are the three major components of the Medicare. And also there are supplementary sub-programs within the Medicare. The Medicare benefit scheme, that is a list of all the health services that the government subsidizes. All the healthcare services are listed with a number. You name it, even just a bandage to a open heart surgery. All these are under the Medicare benefit schedule. There's a list, and the cost is, it's already centrally decided what is the cost of each one. And if you do that in the private care, you can access your care in the private also, all these services. But in most part of this, almost 70% of them, the services you acquire from the private sector is subsidized by the government. So you have to pay only about 30% even if you go to the private sector. And also there is a constant updating of the Medicare. There's a team updating the list of the Medicare benefit scheme. So the list is always, you update it, and the changes and the cost is updated accordingly. And also this medical benefit scheme has a safety net. Suppose your out-of-pocket expenditure, your cumulative expenditure in a year goes beyond certain threshold, you have a facility of dip into the government system for subsidizing, get additional subsidy for the Medicare safety net. That quite often, sometimes it's a large family and 2 or 3 children subsequently simultaneously fall ill, and you may be forced to go to the private hospital, then it's subsidized by the government. So the unreasonable out-of-pocket expenditure is reduced by the Medicare benefit safety net. And also, and in certain year you may have to pay more, and certain year you may not spend on healthcare. But that time also you can approach the Medicare benefit scheme to get subsidies for your healthcare expenditure. And also the pharmaceutical benefit scheme, that's slightly another department, another team. And it helps it makes the medicines cheaper. And without a pharmaceutical benefit scheme, the medicine in Australia would have been more expensive. And the pharmaceutical benefit scheme, they list brand name, generic, biological, and biosimilar medicines. And they list all that. And there are about 5,200 products under this pharmaceutical benefit scheme. And what happens is that the government fixes the rate for this cost of the medicine. And now, in our context, the pharmaceutical company decide what is the cost of a medicine. But in Australia, Australian government decide what is the cost of a medicine, how much they can charge the patient. And quite often, government buy this medicine bulk. So they have better negotiating skill, and this bulk procured medicines are distributed to the public healthcare system. And even if you buy your medicine from a pharmacy, even that is subsidized centrally. So the health financing, one of the major scheme is the pharmaceutical benefit scheme. And the major part is that government is determining what is the optimal cost of a medicine. If suppose one company come to Australia, they want to sell it, and they propose a rate, and the government will they accept it, or they revise the cost and they'll ask for the substantiating to how they legitimately ask for that particular cost, even when their profit is ensured. But still they negotiate it, they bring it down. So the Australian pharmaceutical benefit scheme it regulates the medicine cost not only in Australia, it has got benefit in OECD countries and many other countries as well, because when Australia set the price of a medicine, that's quite often other countries keep an eye on this. And they, in the bargaining team, they can say this is what Australia pays. So this is the nuances of the cost of procurement of medicine. And also all these products are, the safety is ensured by Pharmaceutical Benefit Scheme. And also there's an independent team, they're looking at what are the medicines should be added to the Pharmaceutical Benefit Scheme. This is not only medicine, there are diagnostics and equipments are also part of this Pharmaceutical Benefit Scheme. And also, like other schemes, this Pharmaceutical Benefit Schemes also got a safety net. If your expenditure is going beyond certain threshold, you can approach the Pharmaceutical Benefit Scheme to get your the financial support for your medical care. And also when the other, what I mentioned earlier, the primary healthcare network, that's one of the key components of the Pharmaceutical Benefit Scheme. These are organizations that coordinate health service in the local level. And it could be managed by the local self-help government or managed by it's privately managed but collectively owned. That means it could be a society, it could be a registered entity, but at the same time, it's the board of directors are elected through a membership scheme, almost like our cooperative societies. In Australia, there are 31 public health networks providing different services. And they provide extra services like after-hour services, mental health services, health promotion activities. And you remember that you are a master's in public health students. Most of the public health programs are mostly through primary healthcare networks. And managing primary health network is one of the specialization offered in Australia at the MPH level. Just to relate with your body of knowledge which you are trying to acquire. And also, continuing medical education is part of the primary healthcare network. And when you look at it, there's another step is when you look at health, what is Australian government's responsibility? What you remember is that healthcare is delivered through Australian federal government, state government, territory government, and also the local self-help government. So these are the way, but each one's roles and responsibilities very clearly listed down. Like similar to the Indian context, we have federal government, state government, then we have concurrent list and state list, national list. Similarly, and healthcare in Australia is very clearly defined between federal and state government. And this is not a comprehensive list. I listed some of the services offered by the federal government. Of course, the Medicare benefit scheme is by the central government. Pharmaceutical benefit scheme. Monitoring the quality of the primary health care is by the federal government. And the subsidizing aged care services like aged home, resident home, this is subsidized by the central government. And the data and statistics is central government responsibility. And funding the veterans, what you call the retired from the military army, and the ex-servicemen's support program, their health program, and maintaining the number of doctors in Australia through the Common Fund. The number of doctors in Australian medical colleges is controlled and regulated by the federal government. Then the bulk procurement of vaccine for the national immunization program, that's federal government. In Indian context, still there is a controversy whether it's central government or state government, just to highlight some of the issues. And also regulating the medicine and medical devices through therapeutic goods and administration. And particularly there are certain policies, specific health policies like subsidizing the hearing aid services, dental care services. So just give you examples, they have some kind of specialized health intervention health policies that are often coordinated by the central government. Then the organ and the tissue transplant is coordinated by central government. And the protecting the community, that most of the public health care programs are coordinated by the federal government. When you look at the state, territory, and local government responsibility, managing the public hospital is done by the state governments. And the preventive services such as screening for the breast cancer, immunization programs are implemented by the state government under the overall supervision of the federal government. And also funding and managing community mental health services, public dental clinics, ambulance and emergency services, patient transport and subsidy schemes, means when you're discharged from a hospital, you can get a support from the hospital to go home. They'll get a pocket money to get a taxi. That taxi scheme, even you can hire a Cessna flight if you are in a remote society, in a remote community. You can get an air charter for going home from the hospital. And also the state government look at the food safety and food handling regulation, including the alcohol handling, and also regulating, inspecting, licensing, and monitoring health premises. The premise control, that regulation is also by the state government. And also, like our concurrent scheme, they have shared responsibilities. The Commonwealth shared the responsibility through the Council of Australian Governments. So they decide, and the budget allocation also according to them, from the central pool of the budget, the Council of Australian Government, that is the territory state governments, they decide the quality, and also they decide some of the services and what is the level of funding for the hospital services. And also they are responsible collectively for the pre-cancer screening program, National Bowel Cancer Screening Program. There are a few programs like this, and registering and accrediting the health professionals, that is done at the state level. And also funding palliative care is by the state government. National health emergencies is run by the shared responsibilities. And when you look at the local self-government, like our panchayats, they play the major role. That's one of the difference in the Indian context. Indian panchayats play very limited peripheral role in primary health care. So this is one, if you compare with Australia, the local self-help government plays a very significant role in ensuring the quality and also ensuring access to services. And also, when you look at Australian healthcare system and the financing of the healthcare, means who is paying for the healthcare? That's an important question. And also, depending on how we use the healthcare system, funding comes from the government as well as from the health insurance, and sometimes your own pocket. So that out-of-pocket expenditure is, quite often, it's very minimal. And as I mentioned earlier, Medicare is a foundation of Australian healthcare system. Medicare is a government scheme to give the public access to healthcare, paid through the taxes, it covered through the taxes, and treatment as a public patient in a public hospital, that is done by the Medicare. And also in Australia, there is a name for this public financed Medicare support that's called bulk billing. Means the doctors will treat the patient, at the end of the day, they send the bill to the government based on the government registered level of funding. But also you can go to a private doctor, and some doctors, they will take only the government prescribed rate, but they are allowed to charge as about 40% more than the government rate. But that difference you pay from out of your pocket. And almost 70% of the payment is government will it reimburse it, or it will come to your account, or the government will get directly. And but at the same time, this difference you pay from your pocket. And this is what is done by the private insurance companies. They cover this, or your employer cover. Many of the employment, your contract, your insurance is also covering the private insurance. And also when you look at the public system, means government system, and that also include many components. In the public hospital, community-based services, affiliated health organization owned by the government and by the state and territory government. When you talk about public system, also there are different layers, different type of public system. And also Australian public access care within the public system is free for all, or at a very marginal level, and through the Medicare. Medicare is funded through the Australian taxation. And Australian private system is one of the very limited one, almost about 16% of the total healthcare is provided by the private system. And this is owned and managed by private, such as private hospitals, specialized medical and allied health and pharmacies. So this could be done by the private system. Remember, the private system also a large extent subsidized by the government. For example, take the case of diagnostic system, all your pharmaceutical diagnostic system, most of the diagnostics is subsidized by the government. You go to a doctor will prescribe your testing. Almost 90% of the test expenses is covered by the government. Only very few tests you have to pay out of your pocket, or you have to get the insurance repaid. And also the private system is paying for the private health insurance premium and the private health organization. and people paying directly for private treatment. That's not only for the local people. There are internationally people come to Australia to seek the best healthcare, and then they pay for it at the international rate. And also government increasingly incentivize the private health insurance. So this is one of the major election campaign issue. To what extent you have to privatize the Australian healthcare system? So quite often this is one of the major the election agenda in the Australian election system. And you know that Australia is mostly a bipartisan political system, and their positions are very clear. And one party is always trying to reduce the government involvement in the healthcare system by introducing the private healthcare. So in the election, this is one of the major political bone of contention. To what extent it should be paid from the public exchequer and how much it should be subsidized. And also, there are private agencies, private companies are increasingly paying for the insurance. I'm just giving an example about it. When you look at the health budget of 2019-2020, so when you talk about healthcare in Australia, unless you look at the budget, you may not get the total picture about it. So here what I did is some of the highlights of the national budget. Australian budget for the health is $81.8 billion. That's Australian budget. You can imagine if you look at India, it's almost about $3 billion. So just to give a comparison about the quality and the expenditure on healthcare system, or Australian expenditure is about 16.3% of the Australian total budget is invested in health. And in Indian context, again, it's approximately 1.2% of the national budget goes to the health. So this is one of the major difference in the health financing and also investment in health. And also medical services and benefits, and including private healthcare insurance subsidy, and it cost about almost $37 billion. The pharmaceutical benefit scheme is taking about $12.7 billion, means the procurement of medicine, and the public hospitals and the state hospitals $22.5 billion. Just to give an idea about how much health budget goes to where. Hospital services, mainly payment of state and territory and veteran services, is $1.3 billion. And the health services, actually, all the public health services are listed under health services. Australian public health professionals, when you look at their job opportunities, that mostly comes from this one. That is almost $7.4 billion per annum. That is almost 9% of the budget for health allocation. And also when you look at health in overall, almost about 2% of the budget increase happened every year. And so this is to understand in a situation from a public health perspective. Public health, I'm talking about mainstream public health, MPH students, MPH candidates, they mostly end up in health service. This sector, that's where the MPH, the absorption of MPH candidates are taking place. And the general administration is almost 3.2 billion. And the indigenous population, that's Aboriginal and Torres Island health, that is only 962 million. So just give an example of who is getting what. When you look at the health system challenges, Australia, like many other societies, is an aging population and increasing demand on the health services. That's one of the major challenges. And also Australian chronic diseases, non-communicable diseases increasing. Communicable disease, except the COVID, most of them communicable disease under control. Even COVID, you know that the death rate in Australia is very minimal, kept it very low. And also you have to remember Australia is at the leading cutting edge at the medical research and health innovation. And the cost of medical research is increasing. And if you look at the budget allocation, almost 5 billion is going to Australia promoting medical research and health innovation. So that's what they invest in R&D, research and development investment. And also Australian government's the effort towards the best use of emerging health technologies. Australia is one of the major adopter of the health innovation and innovative technology. They have the health diagnostic equipment. There is a separate department is looking at the quality assurance and also registration of it. And Australia is also very keen on very top in the better use of the health data. And some of you know that Australia, they don't do this routine census anymore. And most of the countries, they do census every 10th year. Even India, we do it every 10th year. But Australia, they, from the last year onwards, 2020 onwards, they decided not to go for the census data because they have almost all the data is in their hand. And out of that, most important data is the health data of all the Australians. So the data management is one of the major challenges in Australia. The changes in the equipments, the changes in the diagnostic, the criteria. So these are some of the issues. How do you monitor? How do you standardize the health data? And at the same time, Australia is increasingly experiencing the health inequity, the rising the cost of the health system, and being able to respond to the new health issues, inequity in access to health services, and the hospital waiting time. So these are some of the expression of inequity. And I just mentioned that indigenous populations' life expectancy and the mainstream Australians' life expectancy is almost 10 years of difference. It was about 20 years, and recently it was reduced to 10 years. This is one of the most important demonstration of the health inequity in Australia, that even they didn't manage to deal with the health inequity appropriately. And also, health is increasingly understood in Australia as a security issue. An Australian government has got a health security research program as part of the Australian government's official program. And they even have an ambassador for the Australian health security and reproductive health services. Australia, you can broadly say that Australia has an ambassador for health. And to engage in a better way with the international trade relations and its implication on health. And also Australia's support for other countries, particularly in Pacific countries, is the broader context of security. And this is becoming very relevant in the context of the COVID pandemic. Australian government support for the Pacific Islands, the vaccine support is broadly legitimized and supported as a health security issue. The concept of health security is very prominently discussed and debated in the Australian public health context, unlike very many other countries. And we know that the US government actually, if you look at comparingly, Australian government recently, just a few days ago, they even passed a bill for the health security, which I've been told that Australian government is also actively looking at creating a health security bill, a legal framework. But already they have it in the foreign policy perspective, it is already there. So Australian government is also facing some of the challenges about how to become relevant in the emerging context, like health security, increasing cost, increasing research, how to utilize research for the betterment, the quality of life and the well-being of the people, and how to reduce inequity, particularly for certain population group. So these are some of the health challenges. Thank you very much. And I'll be happy to take a few questions. And what I did today is just give a very overview about some of the issues and a brief introduction to the Australian healthcare system. And I didn't get into the specific details of the public health intervention, public health programs, and also what are the other specific challenges in terms of disease-specific challenges. I didn't elaborate on that. This is basically a very brief introduction. And if you have any questions, I'll be happy to take it. Thank you. And I'll be happy to share the slides.
Thank you.
Can you, there are some questions posted on the...
Sure, I'm just looking at it. Yeah, right. Yeah. Okay, how Medicare dealing with the social, demographic, cultural, and language barrier and mental health as it keeps on rising. Current pandemic situation, that's question number one. And the Medicare dealing is that's one of the policy issue of Australian healthcare system, because as a policy, they keep on adapting and modifying their health financing. And this is addressed in the healthcare. For example, Australian aged care program is a social demographic response to the healthcare system, because increasingly they have a new elderly care program. The geriatric care program is a response towards the changing demographic structure. And also there are cultural issues and demographic issues. Cultural issues, let me come to that. And some of you may be familiar with the idea or the concept of gestational diabetics. Gestational diabetics is high among the non-Australian population, mostly from South Asian immigrant population refugees. So now they have a separate program within the diabetic control program, gestation diabetes support program, and awareness program for the doctors, mainstream healthcare providers, to understand that there are issues about gestation diabetes in culturally and linguistically diverse population in Australia. So that way, I would say that there are responsive towards changing the social demographic, cultural, language issues. When you talk about language, probably you can talk to a healthcare provider about 7 or 8 languages. You can get an interpreter with the government support. You can say when you go to hospital, you can say that you need an interpreter, because even though you know English, your linguistic sharpness may not be that precise to give a medical answer. So you can claim for an interpreter. So that gives the Australian government acknowledgement towards the linguistic diversity in Australia. And the mental health is now a new program, new budget allocation. Within the budget, they created a national mental health program. And what I remember is about 4 to 5% of the budget directly goes to the mental health program in Australia. That is, they take it very seriously. The mental health screening and the mental health support program, both institutionalized and community-based care, and also daycare for the mental health patients. That's part of the new programs from Australia. And the next question is, since healthcare is covered by central, state, and local government, when someone gets admitted in another province while he or she gets the medical care as a native province, the basic identification you need to get admitted in any hospital is your Medicare card. Medicare card is a nationally standardized, but sometimes when you need a specialized care, and then it get into the differences in different provincial government. And for example, some state government provide better support for the drug users and drug use management program. If you need a long-term drug abuse management treatment program, certain states are much better equipped than certain other states. I'm not naming it now because I worked in I worked in Northern Territory to Victoria, so I'm aware of these changes in certain diseases. The substance abuse is increasingly understood as is a health issue, is a disease management issue. So the better care for the substance abuse is provided by mostly in Victorian government than in some other government, because of the ruling party's dispensation towards the substance abuse. So it varies from, like many other governments are not very kind to the drug users. So their treatment also quality changes. Other than the primary care, the primary care, there is no difference between each province. You get admitted to the national hospital, and national hospitals are all across almost same thing, quality of care. Maybe some differences in the professional skill of the doctors. The Melbourne-based some doctors may be much more exposed to international treatment protocols, or they are actively involved in the medical research. That makes a lot of difference in the quality of care. Whereas in some provinces, the healthcare providers' involvement in the medical research and health research it varies and the quality varies. And similar to the Medicare of Australia, we have a Prime Minister's PMJY in India. Even the framework of the health system is similar to India, but the present COVID crisis management PMJY has not been very successful. What do you think? Where our health system is failing, how we can reduce this gap? To understand the health inequity in India is much more complex than Australians think. To begin with, the amount of resources Australia has got to deal with the healthcare, I told you that it's almost $81 billion per annum goes to health investment. But at the same time, I would say that how India is looking at the primary healthcare is a very important issue, because we invest only about 1.2% of the national budget on health. And maybe I know that I'm touching at the very sensitive boundaries of our discussion. With a pre-warning, let me get into it. Almost 8,000 doctors and nurses died in India because of the COVID pandemic. But my question is that suppose 8,000 soldiers would have died, and what would have been the perception national level? And probably that would have been a justification for another war with our neighboring countries. But 8,000 doctors and nurses, they are committed to save lives. They took an oath saying that we'll protect lives, whereas soldiers, they take an oath, they say we'll kill for the national security. The human security and national security, the dichotomy on a national dialogue in our primary healthcare or healthcare dialogue, it is not part of it. And I would strongly argue that the human security or health security is at par or slightly more important than the border security as in today's context. We invest millions of dollars in our intelligence and military equipments, and none of that investment didn't save us from the COVID pandemic related complications. So that shows we had looked at the understanding of the security should be looked upon in a totally different way. Human health is the most important security. I know I'm touching on some of the boundary sensitive issues, but we need to look at health as a security issue, a national security issue, human security issue. And that thinking is important for our understanding about health investment. For example, if you look at health as a national security, if you demand for reducing 5% of the investment in national defense budget and use it for the health security, people may not get shocked by it. But if I say that India should declare a moratorium and use 5% of the Indian military budget for strengthening our primary healthcare system, probably I may be stamped as anti-national. But these are some of the issues we need to be taken into part of our public health discourse. This is my personal view. This is not an institutional point of view. This is based on my own reflection analysis. So this is my brief answer to this question that why India is not responding to the COVID pandemic. There are many issues, and I just wanted to highlight one issue which is normally part of our normal discourse. And the difference between indigenous and rest of the population, does it mean inequities are still a problem? Of course, Australia inequity is a problem between indigenous population and also culturally and linguistically diverse population and the majority Caucasian population. There are issues about access to healthcare, quality of care, and also if you look at indicators, demographic indicators like life expectancy, I mentioned that almost about 10% of the 10 years of life expectancy is lost for the indigenous population, and the linguistically and culturally diverse population also getting into in between. So there are issues about health inequities. And does Australian Health Service also promote indigenous health system as we do in India, Ayush and local medicine? And the Australian local medicine is indigenous Australians medicine, but that is not organized as like Ayurveda or Ayush in Indian context. And you remember that Australian indigenous population is accepted as a citizen only in 1975. Till 75, they were treated under the Australian flora and fauna laws because they are treated like one of the plants or a shrub in the Australian context. They were not treated like human beings till 75. They didn't have the voting power. They were not treated as a citizen. So this is what you remember. During the Australian indigenous population, they have their own treatment system. But when you talk about Australian indigenous system, you have to remember there are almost 250 subsects in Australia, subsect of indigenous languages. So Australian indigenous culture is not a uniform monolithic entity. Their treatment option, because it's a part of a cultural tradition, it also varies. And their cultural traditions, their treatment traditions are not codified, not done any research on that. And also, I don't even see there is an indigenous population or an exclusive health institution. There is one Menzies Institute in Northern Territory, but that is generally part of the general medicine. They're addressing the Australian indigenous population health, not specifically looking at the indigenous health practices like what we look at Ayurveda or Ayush. So that is one of the limitation of Australian healthcare system. But remember, the Chinese medicine got a Chinese medicine control board in Australia. But this Ayurveda, there is no Ayurveda control board in Australia. Only the Chinese medicine got a separate regulatory authorities. And similar support is not given to Australian indigenous medicine as well. So this is some of the contradiction, even though they are such a resource-rich country, there are issues. And it also one of the bone of contention, the political dialogue, and also these are some of the existing challenges in the healthcare system. And please share the PPT. I'll share the PPT with all. And thank you for the detailed introduction. Could you please explain the challenges and adaptation of the Australian health system during the COVID-19 pandemic? Australian government response is, if you look at carefully, one of the very high-handed response. Even the Australian citizens are not allowed to go back to Australia. I don't think any other country can get away with it, not allowing their own citizen not to go back to their own country. But that's one of the major, the contradiction of Australian response to COVID pandemic. They did a complete lockdown, including their own citizen. That's one part of it. Second, For some reason, Australian intake of vaccination is not that high like many other countries. Australia was slightly slow in absorbing the vaccination campaign, even though now they are opened up. But the initial acceptance of vaccination for some reason didn't catch up with it. And the third is that the Australian COVID response is mostly geared towards quarantining, very strong quarantine. Even now they quarantine people for 14 days. And even if you have a vaccination, that doesn't matter for quarantine. Then there are interstate transportation is complete. There are strict restrictions about it. And in nutshell, Australian response to COVID pandemic is very high-handed, not necessarily respecting the right to health and not respecting in the spirit of the human rights. So this is one of my personal criticism about the way COVID pandemic is emerging. But what you have to remember is that in whichever way it is, they managed to bring down the number of cases, number of death cases is very minimal. So that's one of the plus point of it. But the cost, economic cost and social cost is phenomenal. Is workforce shortage is the challenges in the system. That's one of the major challenges in Australia, is the human resource for the healthcare workers. And I would say in some of the Australian national hospitals, take the case of Darwin, I would say 80% of the nurses are Indian nurses. And I would even say that out of 80%, probably 70% are coming from Kerala. So if you look at cumulatively, maybe Kerala, the government should take a look at it and know what's the contribution of Kerala Health, Kerala human resource for the Australian healthcare. It's not only for Australia, the international human resource contribution from Kerala. And maybe they should have a separate, within the ministry, they should separate department to look at the well-being of the Indian human resources in the healthcare, and particularly in the nurses. And also remember that Australia got the practice in nurses scheme. As a nurse, you can practice like a primary healthcare worker. But that training is not coming from India. You have to get that training once you go to Australia. So I'm just using this opportunity, the need for looking at the Indian medical as well as the nursing workforce, the training methods in Indian context, even the public health, MPH in Kerala, if you're a non-medical person, you cannot get admission for MPH, you know that. And nowhere in the world such system exists. MPH is there is no restriction between a medically qualified person and non-medically qualified. So that Kerala, for some strange reason, you admit only medically qualified person for the MPH program. So these are the summaries when I randomly suggested some comparison since you mentioned about the workforce shortage. And these are some of the general observation about it. And please share my email ID. I'll just do that. Okay. Thank you. And who formulate health policies, like central government in India? The health policies in Australia is mostly by the central government, central health minister. But at the same time, there are nuances in like our state government. There are differences in the policy making. See, for example, COVID vaccination policy is central policy, whereas your quarantine is mostly by provincial government. There are variations about the quality, the monitoring, the duration, all that central government sometimes play, and state government plays a critical role. And also they provide the quarantine facilities. But central government plays a very active role in the active research in the area of COVID response. If you look at the policy response, and also policies related to the diagnostic equipments all come from the central government, not from the provincial government. I think I covered most of the questions. If I missed something, please let me know that, and I'll be happy to take additional questions if you have any.
Any other questions, please?
I don't know whether it's recorded. If you're recording it, I would like to get a copy of it.
Sir, it's live on Facebook, so it will be available in our
great. Okay.
page.
Great. It's your institute Facebook?
Yes, sir.
Great, thank you. Cashier, sir, you have any questions? So thank you for inviting me.
It was a great session, I think, because it's an important area for MPH syllabus also. It's given there, different health systems in the world. So maybe compared to National Health Service in UK? I mean, how does it fare? I mean,
see, Australian health system is a mini version of NHS. I mean, UK healthcare system, and I would say that the Australian system is a clone of UK system. But in my basic analysis, that Australian investment is much more in healthcare system than in UK. So this is one part of it. Second part, UK healthcare system is almost about 80% is run by non-UK born healthcare providers. So this is the second part of it. And the third, Australia, I mean, UK got much more precise research foundation. Even though Australia has got a very world-class research system, the history of research input and research data for policy making is, I would say that it is not at par with the UK. And the third in UK is that there are many international agencies are involved in health system, like NGOs are involved in the health research. In Australia, the health research is mostly confined to Melbourne in the Victoria state, not in other states. So the research input for the policy making is much more rigorous in UK than in Australia. This is my personal observation. And the third thing is that proactive research in looking at health, UK is much more ahead of Australia. It may be because of the small population group and the lack of research, human resource, and also lack of overall human resource for the healthcare in Australia. And for example, even though we send a significant part of the health workforce in Australia, and none of us are in the top level teaching research in Australia. So this is one of the very interesting observations which the people who are producing nurses and doctors and MBH graduates from India, just keep an eye on this. And are we faring at the national level, at the competitively at the leadership level, policy making? Very few are in the policy making. By the way, I had an opportunity to work with Australian government as an Australian senior advisor to set up the Ministry of Health in East Timor. So that gave an opportunity how you create a health system. Now you don't even think about how your health system is created, how the policies are created from the day one. So that's my Australia policy, health policy related involvement and experience.
Okay.
Yeah, thank you, Professor Joe Thomas. It's a complete privilege listening to you. Thank you for enlightening us on Australian health system, and it's a big privilege and to learn from someone like you for the faculty and especially for our young MPH graduates who will be future policymakers. Thank you for your valuable time and the class. We were really benefited. Thank you. Thank you, Naya sir, for bringing him.
Thank you.
Thank you, sir. Thank you, sir.
Thank you, Professor Joe.
Yeah, thank you. I'm just trying to type my email ID, but I don't know, it didn't come through.